Gabriela Kraiter. I'm one of the PGY2 residents, and here's my interesting case. So I have an 18-year-old female with no known past medical history, initially presented to an outside hospital, first on December 20th and then on the 21st to an outside ED complaining of non-specific symptoms with headache, fever, some body aches, some reported weakness in her legs, going on for about 2 weeks. On exam, she had no focal deficits, was ambulating well, some basic labs and COVID and flu screening were all negative. It was thought that this might be a viral illness and she was sent home. The following day, she was presented to yet another outside hospital because her symptoms were still persisting and she felt worsening. Had fevers up to 103 at home, continued complaints of a severe bifrontal headache, and some reported new falls. There, they did her first LP. She had an opening pressure of 35, a pleocytosis of 212 with 88% lymphocytes, mildly elevated protein, normal glucose, cultures were negative, and no other studies were sent off. She was diagnosed with a viral meningitis, but at this point, she didn't have any encephalopathy and could still ambulate, so she was sent home with supportive care. The following day after that, we presented to yet another outside hospital. At this point, she had a second LP, which was quite similar to the first, although they did admit her and started her on IV cyclovir due to presumed viral meningitis. During her second day of admission there, she had a temperature to 102.5, started developing urinary retention, complaints of this horizontal binocular diplopia that appeared to be worse with near vision and with light sensitivity. At this point, it was noted that she was found to have 2 lesions on her outer labia. She reported, I think they'd been there for just a couple weeks. She was monogamous with a boyfriend and didn't have multiple partners. Then the next day on the 26th, she developed severe spinal pain, neck stiffness, and at this point, unable to move her legs. A CT of her entire spine didn't show any epidural process, but given that that hospital didn't have MRI capabilities, they transferred her over to Duke for higher level care and for MRI. On initial presentation to Duke, she was ill appearing, anxious, tremulous. Her exam was notable for neck stiffness and really limited range of motion. It did say that she appeared encephalopathic with limited insight into her situation and just oriented to person and time. Was noted to have bilateral cranial nerve 6 palsies with inability to fully abduct to either side. Arms were anti-gravity, but legs were at best 2 out of 5 with positive Koenig and Budzinski signs. And then she was hyperreflexive in her upper extremities. Initial basic labs on reviewing, now she had a third LP, opening pressure still rising to 46.5, up from 35 on the 23rd, and despite a second LP after that, now with again rising pleocytosis to 290, elevated protein to 139, and then other labs that were sent off, including a meningitis panel and herpes PCR, were negative. At this point, the diagnosis was most concerning for some type of meningitis process, most likely suspected to be viral given the lymphocytosis that she had on her LP, but the differential remained broad, including infection, autoimmune malignancy, or paraneoplastic, as this kind of like persistent course with rising opening pressures didn't quite fit with a viral presentation. While waiting for MRI, she was empirically started on antibiotic coverage with ceftriaxone and vancomycin and continued on the cyclovir that was started at the outside hospital. So workup throughout her admission was largely unrevealing. MRI of her brain and cervical and thoracic spines did show diffuse leptomeningeal enhancement. Otherwise, workup for a cause was really unrevealing. EEG had no seizures, CT, chest, abdomen, pelvis didn't show any evidence of malignancy, transvaginal ultrasound, no evidence of teratoma. And in brief here, I tried to include all the labs that were sent off, and all of them were largely negative. And for her clinical course, she was initially managed with several antibiotics and really didn't have any improvement. Her lower extremity weakness proceeded to be up to 0 out of 5 with inability to move at all at one point. She was then empirically managed with 5 sessions of Plex and 5 days of IV steroids, followed by PO prednisone daily, with growing concern for some underlying autoimmune process. Following her last day of IV steroids, she did start to clinically improve. At this point, she was ANO times 3, appropriately interacting with the team and having conversations on daily rounds. Her legs started to improve with trace movements initially. She's now 3 to 4 out of 5 throughout her lower extremities and able to stand and transfer. And she recently started to spontaneously void as of the other day. Her hospital course has otherwise been complicated by dysautonomia, catatonia, transaminitis, aspiration pneumonia, ileus, a PE, and later COVID-19 infection, all of which have been managed appropriately. The interesting thing about this case is that Mayo later reported back that they had identified a novel neural-acting antibody in her CSF that in the right clinical context was suspicious for some sort of autoimmune encephalitis. And they mentioned it as an unclassified pattern of antibody staining of neural elements on mouse tissue immunofluorescence assays. So at this point, I wanted to include a slide basically on giving examples of staining of other antibodies that we've discovered this far. Many autoimmune neurological syndromes are currently considered as antibody negative, despite some evidence that there are antibody-mediated processes. And autoantibodies are defined as well characterized if their serum or CSF produces a recognizable staining pattern in a fixed tissue-based assay. And if we look at the one with Yo, it selectively stains Purkinje cells. Their identification requires the use of test methods that allow recognition of conformation-dependent epitomes. These commonly include cellular tissue-based assays with unfixed rodent brain tissue, such as the one that we had for this patient. And then patients the serum or CSF of patients are evaluated for the presence of antibodies by binding to the rodent brain tissues and then visualized under light, microscopy, or immunofluorescence. And this approach has been successful in discovering most of the antibodies that we have found in the past decade. And so this was really interesting for me to learn about this process and see a patient that has what might be a new antibody for us. In an overall summary, many patients with autoimmune encephalitis often need an extensive supportive care and prolonged hospital course as they develop many issues that need to be managed, like seizures, autonomic instability, infectious complications, or agitation. And with appropriate treatment, outcome overall compares pretty favorably to infectious encephalitis, with more than 80% of patients having no more than slight disability with a modified Rankin of 2 at 2 years out. However, there is emerging evidence that subtle neurocognitive or psychosocial issues may be more prevalent than we've previously thought. And that's my presentation.
Thank you, Gabrielle. That was wonderful. And thank you for your wonderful care of this patient too. There he is. So it's my honor to introduce Dr. Howard Francis. Howard received his MD from Harvard Medical School, was a resident at Johns Hopkins, and did a fellowship in neurotology and skull-base surgery at Johns Hopkins, where he went on to become professor of otolaryngology and head and neck surgery. Howard is currently the Richard Hall Cheney Senior Distinguished Professor of Otolaryngology and chair of the Department of Head and Neck Surgery and Communication Sciences. In 2020, Howard received the Presidential Citation from the American Academy of Otolaryngology, and he has also been the president of the Society of University Otolaryngologists and director of the American Board of Otolaryngology and Head and Neck Surgery. Howard's research involves the biological mechanisms of sensory neural hearing loss in animal models and surgical, functional, and quality of life outcomes for cochlear implant patients and vestibular schwannoma patients. He is the author of 116 peer-reviewed articles and 27 book chapters. Personally, I've known Howard for 30 years, since 1991, when we were both trainees at Hopkins. Howard was one of the handful of surgeons I knew there who was both truly driven by his own intellectual curiosity and a desire to make a difference. It was always a joy to run into Howard in the emergency room or the wards because his equanimitas was legendary and his gentle smile and positive attitude were the perfect cure for cynicism and burnout. I can't express my happiness at hearing in 2017 that those accidental encounters would begin once again at Duke. Speaking for all the members of the Department of Neurology, I'd like to welcome my friend Howard Francis. The title of his talk is Aging in the Inner Ear. All yours, Howard. I'm going to start crying.
Rich, thank you so much. And, you know, given that it was really the neurosciences that brought me, first of all, can you all hear me?
Yep.
Yeah, the neurosciences that really brought me to otolaryngology, stole me from internal medicine and from infectious diseases, which really is what I went into medicine to do, but just was absolutely amazed by the nervous system. And, but also discovered that I wanted to be a surgeon. And so otolaryngology and neurology have really been a tremendous gift to me. But the most exciting patients and encounters and you know, challenges that I have encountered, medical challenges and curious cases that I've encountered have really involved neurology. And indeed, Rich, I remember us working together on several fascinating cases, even during my residency and through my career. So I am indeed honored to be asked to share something that I care a great deal about, the inner ear, and hope that it will be a benefit to you all in some way, and hopefully to our ongoing collaboration as two departments. So let me share. So this can sometimes go haywire. Oops, that's not
Working.
That's actually not the one that I want.
No.
Let's see. Let's try that again. It's interesting. It worked before. Let's try that one. So that will work.
We had one there for a couple seconds.
Yeah, but it's the wrong. Let's see if that will. Are you seeing notes, or are you seeing?
Nope, we don't see any notes.
Okay, you're seeing the main
Yep.
talk then. Okay,
Yep.
Thank you. All right, just want to be sure. Yeah, aging in the inner ear and implications for population health. I only have some unpaid connections that might be perceived as conflicts. My objectives are listed here. We'll try to hit these in the next 40 minutes or so, or however much time we have. Just an overview of hearing transduction, which is really what gets me excited in the mornings. Discussion of age-related hearing loss, its mechanisms, and sort of what's happening at the population level, our approach to treating individual patients, and then looking at the broader implications of hearing loss to health, both at the individual and at the population level, and its policy implications. So the beauty of the inner ear is that it's this mechanoelectric sensor that is able, in the case of the cochlea, to detect auditory perturbations, auditory signals that can then be coded and transmitted to the brain for interpretation. But within the inner ear, we also have the vestibular end organs that David Zeed spoke so beautifully about a few months ago, that in using similar mechanisms can detect you know, acceleration relative to the utricles, the utricle saccule, or the macula rather, and the ampullae of the semicircular canals. Now, as it relates to the cochlea, the passive structure, the mechanical properties of the bone and of the fibrous tissues that make up the cochlea are in their own right tonotopically organized and tonotopically tuned, such that at the base of the coil, sounds entering the inner ear will perturb the basal turn for higher frequencies will perturb the basal turn versus low frequencies that will perturb the apical areas. And this just really elegant structural characteristic of the cochlea where led to a Nobel Prize for George von Békésy in his work in defining this. But then this passive tuning of the auditory periphery is further refined by the active mechanoelectric transduction processes really induced by the stereociliar hair bundles at the apical portion of hair cells. And these produce nanometer movements that produce potential changes in hair cells, which of course generates a neural synaptic signal, and within the auditory nerve, a signal that can be sent to the brain. And this is the business end of the basilar membrane. We talked about the passive properties of the basilar membrane. Well, the active, the additional active function or physiology of the organ of Corti, which consists of inner hair cell, a row of inner hair cells, and 3 rows of outer hair cells, further refines that tuning process such that every nerve that innervates the cochlea is very tightly, very sharply tuned. And what does this do? It really allows us to really encode pretty complex sounds that are salient to language. So our ability to use verbal language is based on the diversity of speech sounds that can be produced by the vocal tract. Each one of these sounds is distinguished by its unique composition of frequencies. And so this is these are spectrograms of various phonemes that show the frequency bands that characterize them. And these peaks of frequency energy are called formants. They're typically, there are many peaks, but the 3 lower frequencies, the first, second, and third formants, really are what the brain uses to differentiate any one phoneme from the other. And what this really allows us to do then is to distinguish, according to first, second, and third format for the brain, very distinct characteristics, frequency characteristics of each sound. Now, presbycusis, or age-related hearing loss, is likely a heterogeneous group of disorders that result in progressive degeneration of normal peripheral auditory function that either accelerates at advancing age or through cumulative injury over time becomes more rapidly evident at older ages. And Schutnik of the Massai and Ear categorized some of this work. Some of the earliest work was done at Hopkins by Crow and Guild, and others have contributed over the decades. But Schutnik came up with this categorization where he described sensory, which is really a loss of outer hair cells and an elevation of threshold beginning typically in the low frequencies. And so here we have a cross section of that scanning electron micrograph that I showed earlier, nice colored one. This is a light micrograph. And we see that within this central compartment called the scala media, which is very potassium rich, we have our outer hair cells, our inner hair cells here, and we have a vascularis, which is metabolically extremely active and keep maintaining the necessary electrolyte concentrations that allow for favorable transduction processes to occur. So as these outer hair cells are lost, the tuning properties of the cochlea decline. There's also a neural form of presbycusis, which is primarily not so much sensory loss as much as primary auditory nerve fiber loss, which enters the cochlea here. And this is increasingly now recognized as being related to postsynaptic excitotoxic effects secondary to noise, that leads to synaptopathy and the loss of these fibers, even without a change before threshold starts to increase. Then there are disorders of the lateral or the strata vascularis and spiral ligament, which are metabolic in nature and then conductive. So the etiologic agents are individuals, just time is be the most important one, but there are genetic predispositions that are being better defined. The cumulative effects of noise, this is a non-regenerative structure, and ototoxicity are all factors that can contribute. And so what we can see happen then as the hair cells are lost and as the tuning process changes from a sharply tuned to a very poorly tuned system is that we have a breakdown in the ability of the cochlea to deliver a clean signal of what is being said, for example, to the brain. And so here we have a spectrogram. Again, frequencies are nicely sharply defined by these bands over time, and then the colors represent different intensities. We see that the signal being generated by a broken cochlea, if you will, or an age-related, in the setting of age-related hearing loss, is not only a reduction in ability to hear these sounds, but actually a breakdown in that clean signal. And so it's very common for individuals to have great difficulty understanding speech, even though they can hear that they're being spoken to, they don't understand what is being said. So how prevalent is this? It grows, it doubles almost every decade, such that for those 80 years and older, about 80% of those individuals have some level of hearing loss, and the distribution to more serious hearing loss, of course, it also increases with age. So it's quite a common problem, and of course, our populations are surviving other major threats and are living longer, fortunately, particularly in medium and higher income countries. And this projection just shows how much our population is aging, and which is a sign of success. But the overall burden, what this means is the overall burden of hearing loss is growing in the population, and it's becoming particularly prominent in these middle and high income countries. So what does this mean for the individual, with hearing loss? We look through the lens of the provider. What does this really all represent? I think it's important to just say that this does represent for the individual increased demand and cognitive reserves associated with mental fatigue and emotional and has emotional consequences, of course, further exacerbated by the stigma that comes with the idea of having a hearing loss, the idea that you're getting older. And this may mediate some of the increasingly evident consequences of hearing loss. So certainly effortful listening is not something that we have a good measure of, but patients describe very eloquently just how completely wiped they are at the end of the day. Even though they perform well in school or they perform well in their jobs, they are finding it really hard to keep up. And as there comes a point where they aren't able to anymore, and that leads to miscommunication. Their increasing dependence on lip reading and their increasing difficulty hearing the noise tends to limit then their involvement in their social involvement. So certainly there's embarrassment, there's stigma, there's stress, and then we have these behaviors that lead to avoidance and increasing isolation and loneliness. And so our approach to these individuals is to maintain perceptual access to phonemes using amplification. When speech perception with a hearing aid, though, drops below 50%, they're lip reading or needing to use visual input to gain access to 50% of what is being said, then the hearing aid, we need to look at other technologies that might, reduce that effort and its consequences. And so at that point, we would consider, where appropriate, cochlear implant. Certainly attention to auditory skills and self-advocacy, including the use of technology and other resources to mitigate the challenges of listening, even with the best available technology. This is important. And this should include auditory training, and then finally managing signal to noise ratio, microphones, earbuds, and other technologies. So this is just a general approach to how we would address this as hearing professionals. And when I say we, I mean audiologists and speech language pathologists and otologists. And certainly, although amplification enhances detection of the speech sound, if we have these spectrograms that are darkened because of increasing levels of hearing loss, you add a hearing aid, and I'm just trying to give a sort of a visual simulation of what this experience might be for a patient where, oh, now I hear better, but depending on how much distortion there is, they may hear better but not understand any better. And so as that level of distortion increases, we have to turn to more invasive approaches, which it really represents a 2-hour outpatient procedure in a healthy older individual. It's very well tolerated. It does involve, this is my only surgical slide, so you don't need to cover your eyes anymore, is a mastoidectomy here where we have open into the mastoid. We have the incus here in the middle ear space, and the malleus next to it. We have skeletonized the facial nerve and the chorda tympani, and created a window between those two structures to gain access to the cochlea. And we've opened the cochlea and we've inserted an electrode array. The electrode array is attached to a receiver stimulator device that will be receiving input transcutaneously from an external processor, speech processor. And so that is the cochlear implant, and it does a sort of it only captures the key formants, the key frequencies that are absolutely critical for distinguishing individual phoneme sounds in speech, and using a processor that is constantly improving over time. But I would say that show what a typical result is. If we look at thresholds, there are several ways in which to define success. One is, well, how sensitive is the hearing? How much is the acuity of the hearing acuity improved? And this is an individual patient of mine who lost hearing very quickly due to autoimmune ear disease that became profoundly deaf. Normal hearing would be up here. And receive a cochlear implant, and with their implant now has hearing discrimination or hearing thresholds that are just at the borderline of normal. But that's just part of. Now, what about the clarity question? This is a population of older patients, older than 60 years, who received the cochlear implant, and in the course of after 6 months, so we have our pre and our post 6-month speech perception measurements. And we have sort of two different groups here. One group where the most deaf group, where their speech perception at the baseline was 0 to 40%. And for this group, we see that the majority of them show an improvement in speech perception. Many of them are receiving well above 80%, and you have some variability, some receiving not so much. For the subgroup that had more hearing present, meaning their speech perception was not as poor, it was more 40 to 60%, we see pretty much uniformly all of them getting very close to 100% speech understanding, so significant improvement. But overall, this is what we expect, is to see that most of our patients have improved access to speech. And the longer we wait for them to go deaf, the more uncertain the outcome. Earlier intervention will likely produce a more favorable result. But this is just an example of what we would expect to see. Now, if we look at more broadly across the population, as these consequences of hearing loss permeate our aging population, we have become aware of strong associations with poor cognitive and general health outcomes. But this is more looking at it at the population level. The population health implications are increasingly evident, such as the finding that you're probably all aware of as neurologists, finding by the Lancet Commission that had really done a deep dive into the literature, and were able to demonstrate just how relevant or how significant hearing loss plays a role, or certainly be as a predictor, and seems to be a modifiable risk factor rather for future dementia, to the extent of somewhere around 9%, accounting for about 9% of the variability. And certainly other work that has, so there's a 1.5 to 2.67 times chance of dementia in the 19 to 17 years after the diagnosis of hearing loss. And also an English longitudinal study of aging, which the association has only seen in untreated hearing loss, but in individuals with hearing aids, there was less of hearing loss was less of a risk factor. So maybe an indirect evidence that hearing loss is indeed a risk factor, but that maybe mitigating hearing loss might lower the risk. But that study has yet to be done. One is being done now, and it's a very large study being done by Frank Lin at Hopkins, and we're very much looking forward to see what the results are. So that's dementia. How about the just broader health implications of hearing loss? And this is a study using NHANES data over several years worth of data by Frank Lin's group in our department where I was at Hopkins. And here he looked at the subgroups of patients with various levels of hearing loss and how that correlated with their health outcomes. Group that had normal hearing, had mild hearing loss, moderate hearing loss, severe hearing loss, profound hearing loss. And the primary outcome of interest was hospitalization in the previous 12 months and burden of disability in the previous 30 days per the NHANES data. And this is, I'm sorry about the table, but just to focus in on these models, this is the base model taking age into consideration. So when age is taken into consideration, there's a 33, for every 25 decibel worsening of the hearing threshold, there is a 33% higher rate of hospitalization in the previous 12 months, and about a 30% higher rate of poor burden of a sense of increasing disability as reported by the individual. And this remained true regardless of whether you took into consideration race, education, income, and cardiovascular risk, suggesting a very strong independent correlation between hearing loss severity or untreated hearing loss. These are individuals who typically did not have any intervention, and a variety of health manifestations. We here in the department wanted to ask the question, well, what does it mean in terms of perioperative risks? Can we identify any relationship? Are patients with unaddressed hearing loss having different experiences with, in the perioperative period, particularly around surgical complications and their hospitalizations? And there are a number of things that we know amongst older patients undergoing elective surgery that can predict poor outcomes: chronic morbidities, clinical functional status, impaired cognition, poor nutrition, reduced mobility are all known and well established. And the question was, what about hearing loss? And we leveraged a database that had just recently been developed to pulling all of the data from the EMS around surgical care, actually all care at Duke, and the Pythia, it's called a Pythia database. And we were probably the first study to publish using this database. And it contains records from 2014 to 2017 at that time. And we excluded individuals under the age of 65, individuals obviously not undergoing major elective surgery, and individuals undergoing otologic surgery. So we did not include people with hearing or ear-related problems. So all of these were individuals undergoing major non-otologic surgery older than 65 years. And then we wanted to cross-reference this database with an audiological database, diagnostic database in our own department called Audibase, to really then be able to correlate the hearing, characteristics with these surgical outcomes. And we excluded, obviously, we only included in that database individuals that had the appropriate no data missing at appropriate times. And we ended up with a final cohort of surgical patients older than 65 years old with audiological data available, performed before surgery. And there were about 742 of those. There were 742 of those patients in that database, that final database. So we conducted regression models to fit each outcome of interest, and we adjusted for age, race, sex, and comorbidity burden using the Elixhauser Comorbidity Index. There, just to show how the two groups varied, we had 193 with normal hearing. We had 549 with various levels of hearing loss. And they're relatively similar ages, slightly older group for the hearing loss group. And we found that in general, the hearing loss group had more comorbidities, which is consistent with all the data that's available. But our group similarly were sicker. So we had to account, and certainly had to account for these confounders in our final analyses. So the primary outcomes of interest were, first of all, complications. And these were both minor and major complications, most of which led to at least a prolongation of hospitalization. We do not have any mortality information or perioperative mortality because that was not included in the PIFIA, so that is lacking. But you do see a difference here in quite a large difference, significant difference in the rate of complications amongst individuals with hearing loss. Slight difference in length of stay, and very minimal difference in the 30-day readmission, though 90 days that certainly grew with patients with hearing loss having a higher rate of readmission. If we look at this more robustly and in a more statistically careful manner, our models really point to, while accounting for age, sex, race, and comorbidities, we do see that for every 10 decibel increment of hearing loss, there is a 14% higher likelihood of a postoperative complication. And this is the kinds of complications that we saw. Cardiac were the most prevalent, but then we saw also a variety of other types of complications. So, what does this all mean? Is hearing loss just simply a biomarker of increased vulnerability in the perioperative period? Is miscommunication a part of the problem? Miscommunication leading to discharges that within the hospital in inpatient experience and or post discharge. Is this further reason to include hearing screening as a routine part of general health assessment in our older population that are undergoing surgery? Should this be sort of a new health status sign that we take into consideration? And what if we enhance the patient's communication experience by training our providers, providing amplifiers to hear in patients with unmanaged hearing loss, so that their journey through the inpatient stay is improved? Or even as we think about designing hospitals, really pay attention to some of the acoustics that can support communication. What about all those things? Well, it does require that we, as health providers, really work with our nursing colleagues, with other disciplines, with administration to really bring about some increased awareness and some changes that can mitigate these risks. And we are in the process of trying to do that with a DHI proposal that hopefully will allow us to reduce some of that burden in the perioperative period. But I think there's a broader question: why is hearing loss so strongly associated with these things? I mean, who would have thought? You know, Franklin was one of my mentees, and he, as he was finishing his PhD, thought that, you know, Howard, I think I want to really, he was looking at young children, looking more at the pediatric population of hearing impaired, and wanted to, saw, you know, there's a problem at the older group that we haven't figured out. I think I want to look at that group. And he started really looking at the health status, the statistics and related to hearing loss. And he's really brought about in the last 10 years a whole new way of thinking about hearing loss and its population effects. So certainly there are possibly it's just an epiphenomenon, but at the very least it's a marker. But what about mechanistically? What could we hypothesize as explanations for this strong correlation? Is it the known cognitive burden related to hearing loss that might, in some manner, speed up the process to cognitive decline? I don't know how that would impact physical manifestations. I don't know. Depression, we know that there's a higher rate of depression associated with hearing loss, and maybe untreated depression certainly changes some of our biology. And then isolation, you know, the changes in behavior that lead to patients becoming less connected socially. That, I think, is one of the more prominent and more promising explanations. And isolation by itself is a fascinating concept, a discrepancy between a person's preferred and actual level of social contact. And there's just growing data to show some of the biological consequences and some of the health consequences of isolation, with higher rates of death, and even in animal models that are of isolation, for example, larger stroke size and associated with some epigenetic effects in mice, which I think is fascinating. So we do know that there's a higher rate of isolation associated with hearing loss, and this is there's a negative correlation between age and loneliness, and that this can also be associated with exacerbated by socioeconomic status. There is fortunately also evidence to suggest that management of hearing loss can lead to an improvement in or a reduction in isolation. And this is a study that compares baseline UCLA score for isolation compared to the change after an intervention in the case of patients who are candidates for cochlear implants. These are individuals with the worst hearing, who have also the worst isolation scores. They are also more likely to have the greatest improvement in their self-reported levels of isolation using this instrument. The hearing aid group had lower levels of isolation. They were less impaired, still benefiting from their hearing aids. Did not show an effect with this instrument. But I think that this is just some early evidence that perhaps we can influence isolation. Now, its impact on health effects down the road is really still needs to be defined. So, you know, what are the policy implications of what I've just talked about? You know, we are have the most expensive healthcare system on the planet, and our outcomes are really not living up to that expectation. And so a lot of that there's a lot of reasons for that. Some of it is the way that we have structured our payment system. Some of it is our lack of addressing disparities, racial disparities and socioeconomic disparities, and the like. So certainly this is of great importance to the full political spectrum and to all of them, and behooves us to sort out what some of the underlying causes are for this major lack of link this major issue with rising costs and not raising health outcomes. And I think this is reflected on a variety of different ways in which the healthcare system has tried to change the payment system, heading into value-based care, which is really at our doorstep. We're really at the doorstep of value-based care. We're sort of still in that fee-for-service mode, very heavily still in fee-for-service, but with one toe over that value-based care line, which of course de-emphasizes a fee-for-service and promotes more of a bundled payment approach and a more population-level approach to responsibility, where we can share savings and share also risk. Certainly, we are, if we think about what I talked about regarding the perioperative complications, I talked about some of the other downstream effects of hearing loss, and even for this example, where there is an average of 4 to 6.5% increase in healthcare costs and a 4 to 4% increase in risk of 30-day readmission over a 10-day period amongst individuals with hearing loss. You know, what does this do to our value-based care formula, if you will? It certainly negatively impacts the quality. We see that, and the costs, and so we think that there is a significant room for us to better characterize how this growing burden of hearing loss of population can be considered as we prepare for value-based care reality. So as hearing care professionals, we are called to increase our collaborations with other health professionals to begin with, the community, as well as the community and families, according to a social ecological model, to identify and mitigate risks related to hearing loss in the broader population. And one of our major barriers is that hearing is not actively screened in primary care or community settings. We don't even know this is a silent disability, and it's a silent, people through stigma don't necessarily feel comfortable talking about it, nor do we necessarily ask about it. We certainly don't screen for it. But as we think about a social ecological model for approaching this interface between the aging experience and hearing intervention, it certainly is not going to work. We cannot do this from the comfort of my office in 1F or my clinic space in 1F or South Durham. This is really going to require an all-out effort to work with a variety of different stakeholders. So what might this look like as a population health strategy? You know, if this is a biological marker, at the very least it might be of increased health risk. You know, certainly if we can identify individuals with unmanaged hearing loss, at least we can understand how that might, or project what that risk might be. And so it certainly can be used to help with risk stratification and mitigation efforts. We can certainly identify individuals who are at risk for miscommunications during their hospital management. They're through very well-defined health encounter, whether an outpatient or inpatient health encounter, our ability to enhance that patient experience so that they don't feel uncomfortable asking questions because of the stigma related to doing that, and that we're really facilitating them talking about this part of their experience so that they can get the help that they need. Early diagnosis and treatment, certainly integration into routine primary care would help. That is where most of our aging population interfaces with the healthcare system for preventative care, and this should be part of that preventative care approach, as it has been actually determined by Medicare. But the actual role of hearing screening has not been really settled. Easier access to interventions and reducing stigma in the patient experience. These are all issues that I would love to, each of them demand their own hour, but really require that we pay attention to all of us, not just the hearing professionals, because we all play a role in that. And then the social isolation question really demands that we interact more with partners in the community and sort resource in the community to help address that. So these are all opportunities for us to change some of the downstream effects. And we have conducted a study under the leadership of Dr. Deborah Tucci before she left to serve as the director of the National Institute on Deafness and Communication Disorders. She initiated an NIH-funded multidisciplinary and interprofessional team to really evaluate the effectiveness of hearing screening in primary care. And this was all done here at Duke, and these are members of the team who have played a role. And you've seen, I'm sorry, I didn't introduce Sherry Smith in my previous slide, who is our chief of audiology and led that previous study and the perioperative risks of hearing loss, and is now really leading this team as Dr. Deb Tucci is not here anymore. And so the background, really quickly, as we come close to the end here, is we really wanted to, yes, actually, I'm going to go ahead and skip all of this. And it's needless to say, this we really wanted to understand how we inform best practices for hearing care, and to determine what level of involvement the primary care practitioner could play in hearing screening. And so we had 3 screening protocols that varied with varied levels of clinical support. One, just we introduced the concept of hearing screening using a telephone process tool that the patient could do at home. The second was one in which the physician provided encouragement that the patient perform the screening at home using this telephone tool. And the third, the patient was able to conduct the telephone screening in the office itself. And the I'm going to jump straight to, these were 65 to 75-year-olds, and they were not currently a hearing aid user, or did not have a known history of hearing loss in the past. And we have 110 participants. But we had 220 in each of these groups that were distributed across several primary care offices. And we see that those who, this is the percentage of individuals who completed the screening. See that all of the individuals who were assigned to the in-clinic screening completed it, and only about a quarter of those who were either given instructions or encouraged completed it. But notice that those who completed it at home had a very high rate of hearing problems, so they probably already knew they had an issue, and versus only about half of those who completed it in the clinic. And we can see that various percentages of these individuals then moved on to formal evaluation, completed the evaluation, and were given recommendations for hearing aids. So we see that physician encouragement was not influential. Just giving people the information certainly was as good, and but still only 25% really ended up completing the screening. And whereas providing support for in-clinic screening was certainly influential. So we look forward to partnering with you all in reducing the burden of hearing loss and social connection and independence with the aging experience, and the broader health of our population. And I really appreciate your attention, and hope that we have time for questions.
Thank you, Howard. We have plenty of time. Anyone who needs to move on can and will do that. So thank you so much for that great talk. I've got some questions, but I'm going to throw them to people who have their hand raised, or people who enter their name or their question in the chat, and we'll call on you. Okay. So Wayne's going the other way just by raising his hand. Wayne,
hey, Wayne.
You take it away.
Hey,
how are you?
Good seeing you today. I have to run the clinic, so I'm gonna do my question. Okay. So in the stroke care, we pay a lot of attention language deficit, motor impairment. Now we start paying a little bit more attention about cognitive impairment and vision. But we really neglect about the hearing loss and in stroke patient. Do you think we also should initiate some of the screening process in stroke patient? And you know, especially in the youngster, I just feel they are significant neglect, being neglected, and especially, you know, before you initiate a speech, you know, therapy, maybe you should also implement in hearing loss screening to ensure they actually can hear.
I think what you just said is brilliant. It's exactly right. And I think you're looking at the holistic, you know, communication function of that individual is important, and optimizing it does require that, you know, have an understanding of what their auditory capacities are, and optimizing those would be a very important part. I think it'd be interesting to look at your stroke outcomes relative to hearing status. Maybe that's something that could be looked at as well, baseline, and then have an intervention that you really look at that.
Yeah, thank you.
Thank you, Wayne.
Thanks for the question. That's a great question. Thanks.
So Howard, we have a question from Dr. Shah. I'm not sure if he's still out there, but I'll take a shot at it. Does prolong, oh, there you are. Dr. Shah, take it away.
Hey there, Dr. Howard. Thanks
Hi.
for a very intellectually stimulating talk. I really enjoyed it. So in our clinic, we constantly have this white background noise, so we can prevent one room to other room communication and stuff like that. And one of our provider raised the question that is there any good quality data that continuous exposure to white noise increases person's risk of having a late life hearing impairment. That also ties into a lot of my patients when they have sleep issues. I tell them to use a white noise. So I feel like a lot of people are using a lot higher amount of white noise now than they used to. So do we have any data on whether it increases the hearing loss down the road? Thanks a lot.
Yeah, no, thanks for the question, Dr. Shah. You know, I think a couple of things come to mind as you ask the question, and one of them is, first of all, I think the question you're asking is the safety of white noise over time, exposure to white noise over time. And the data, you know, OSHA has a lot of data on that kind of information, as it has really put a lot into characterizing the long-term effects of noise in the workplace on hearing outcomes. And, you know, it's really not so much, so there's known amount. And so the measurement of that noise is going to be important. If there is a concern about safety, you know, knowing what that dB level is will be helpful. And then, you know, applying it to those standards. But just white noise by itself per se is not dangerous. And, you know, no, it's not. What I also thought you were going to ask initially was how it impacted communication in the clinic for your patients who have hearing loss and that has not been characterized, not been treated. Even those with hearing aids, that a lot of background noise just sort of makes it more, not only makes it more difficult for them to hear their providers, but it really just breaks down the quality of the sounds, the quality of their ability to discern and to discriminate words. So that's the other piece that might be worthwhile also thinking about. Yeah.
Thank you.
All right, Howard, so I reserve the right to ask questions, and I have 3 questions / comments. You can decide which ones you want to answer. I have to believe that hearing loss is going to be associated with in-hospital delirium, so that,
Yes.
you know, that would seem to be a huge issue. Number 2, none of our patients will wear their hearing aids. How do we get that to happen?
Mm-hmm.
And number 3, I've read a little bit about cochlear implants, and it's not like you put one in and the patient instantly hears. Their brain has to learn how to hear. And that has to be dependent on brain health and the presence of incipient dementia and things like that.
Yeah, no,
It's
those
not
are
a
all,
question, that's a comment, but yeah, take it away.
those are great. And I'm gonna maybe wrap up here because I have to go to another meeting, but I'm gonna, the first one, I need some cognitive help.
Delirium.
Delirium. Yes, so that is one of the things that we are looking at further evaluating. And you're right. I mean, a lot of our patients don't wear their hearing aids. their thought is, well, I don't have anyone to talk to, so why am I wearing my hearing aids? It's just my husband or it's just my wife. Why do I need my hearing aids? They don't understand that they really need to wear the hearing aids in order to really develop a capacity to benefit from them. You can't just put it on and have it work. There is a learning curve. And the same is true for cochlear implants. There is a whole new way of listening that requires time and experience. But what I would say is that patients with hearing who are lucky enough to have hearing aids, I think it really behooves us to at least know that there is a protocol by which when they're hospitalized, those hearing aids are getting their batteries changed, that they're on the patient and that we're keeping track of them. For those who don't have hearing aids, that's more challenging because, our thought is, well, we can get some inexpensive amplifiers that we can use for that, for those encounters while they're hospitalized. So these are real issues, and it's not so simple as slap it on and solve hunky-dory. There is a whole nother level of complexity that we have to work out as well in terms of operationalizing these concepts.
Yeah.
Thanks for those questions and those comments.
And I thank you for your doing grand rounds today. It's great to have you at Duke, and we'll let you go on to your next meeting. Thank you, everybody.
Pleasure to be with you all. Have a great rest of the week.
Stay safe.
Thank you, Rich.
Bye-bye.